Hello, everyone. Welcome back to Operation Critical. Today, we're talking about a very important topic across all domains, and that is that of upper GI bleeding, a classic emergency that every clinician needs to be able to recognize and manage fast. We're talking about hematemesis, melena, and sometimes massive shock. So let's break it down. The definition: an upper GI bleed is defined as bleeding proximal to the ligament of Treitz. That means esophagus, stomach, and duodenum. The classic signs, we'll break it down by type. Hematemesis, vomiting blood, which would either be bright red or coffee ground. Melena would be described as black tarry stool. Hematochezia can occur if the bleed is brisk. Also look for orthostasis, syncope, and hypotension. This is signs of significant volume loss. The most common causes, number one overall, is going to be peptic ulcer disease. So watch out for this on tests and anytime you suspect someone with an upper GI bleed. Esophageal varices, especially in liver disease and your cirrhotic patients. Mallory-Weiss tear from retching, gastritis or duodenitis, and erosive esophagitis, and in less common cases, malignancy, angiodysplasia, or a Dufloy lesion. So the initial approach, as with most trauma cases, is going to be A, B, C, D, E. So essentially, step one, stabilize the patient. Airway, protect if they have an altered mental status or massive hematemesis. Breathing, give oxygen, and of course, get those two large bore IVs started to start fluid and have blood ready. Then, on the backside, you can get a CBC, a BMP, LFTs, and coag panel, type and cross match. Sometimes they'll place an NG tube. It's optional, not always necessary. And consider ICU admission if they're unstable or you suspect variceles. As far as pharmacological treatment goes, start empiric meds ASAP. Those are going to be IV PPI, like pantoprazole 40 mg BID. Those are for all patients. If you suspect varices, it's going to change a bit. You'll still have the IV PPI, but you can add octreotide drip for splanchnic vasoconstriction, ceftriaxone for prophylactic antibiotics, and you can consider lactulose if they're encephalopathic. Stop NSAIDs or anticoagulants if possible. The next thing we need to talk about is endoscopy. Endoscopy is key and should be done within 24 hours or sooner if they're unstable. It allows for diagnosis and treatment because we can go in there, we can see it, we can clip, we can cauterize, and we can band. For varices, we're going to band. For ulcers, we can do an injection, thermotherapy, or clips, or a combination of all the above. We'll transfuse packed RBCs if hemoglobin is less than 7 and the patient is unstable. Our goal is 7 to 9 in most cases. We'll correct coagulopathy. We'll give FFP if the INR is high, platelets if below 50K and bleeding. And of course, if there's need for a massive transfusion, we'll use 1:1:1, RBCs, FFP, and platelets. There's a couple ways to stratify risk. There's two scoring methods you should know. The Glasgow-Blatchford score, pre-endoscopy predicts need for intervention, and a Rockall score, which is post-endoscopy, and that'll predict mortality. Essentially, a quick recap, don't delay endoscopy in high-risk patients. Always assess for varices if the patient has cirrhosis and treat accordingly. Rebleeding is common, so after anything, procedures, monitor vitals and hemoglobin closely. That about wraps up this quick session. Just remember, upper GI bleeds are fast and dangerous, but they are treatable. Your thoughts should be stabilize, medicate, scope, in that order. Know your differentials, act early, and save lives. Like, subscribe, and stay ready for the next code.